Hello and welcome to the Nutritank podcast, where we interview leading experts within the field of food systems, nutrition, and lifestyle medicine. Our aim is to empower you, the next generation of healthcare professionals and change makers. We believe that the valuable knowledge and experience of our guests will inspire you to act and join the movement in creating a healthier population.
Hello everybody, Luke here, Nutritank member and nutrition student. We hope you enjoyed the previous episode where my co-host Ian interviewed the inspiring Dr. Broadley Westerdown. They dive deep into the field of nature therapy and discuss how we can unlock the benefits of nature for both patients and healthcare professionals. Now, it's a topic very close to my heart and a wonderful chat, so if you haven't checked it out already, I warmly invite you to do so. In this episode, I speak with the fantastic Dr. Shahrukh Mallik. Shahrukh is a consultant neurologist with 18 years of clinical, research and teaching experience. And as well as his busy NHS work, he also helps clients optimize their health via the London Centre for Longevity and Metabolic Health. He sees the body as an interconnected system and helps patients and clients to understand their body and health from a metabolic perspective. So, Shahrukh, welcome to the show.
Thank you very much, Luke, for having me. It's a pleasure.
Yeah, well, it's a pleasure to be here. I'd like to start by talking a little bit on where I first came across your work. Similar to Sophie True, another guest we've had on this series, I heard you give a talk at the IPMC conference back in June. And not only did I hear you speak, but I was holding up the timesheets in the front row, alerting the speakers to when they had 5, 2, and 0 minutes left. So first, and most importantly, I'd like to thank you for keeping well to time and saving me from vigorously flapping my laminate sheets in front of the crowd.
No problem at all. Thank you for your help on that day. It was a fantastic conference, actually.
Yeah, so it's called the IPMC, and I think the IPM part certainly stands for Integrative and Personalized Medicine. During your presentation, you described modern neurology and modern medicine as a whole, for all their merits, as short-sighted, tunnel vision, and compartmentalized. How would you say that compares to what we think of when we describe integrative and personalized medicine?
Well, human beings aren't just walking brains or walking lungs or walking, digestive systems. They all are part of the whole. And what we're beginning to realize, and we've done so for some time, but I think we've lost sight of this, is that if you see someone as an integrative whole, their metabolic health, their physiological health, you're in a much better position as a doctor, as a caregiver, to actually give them the care they need, rather than saying, well, they've got this one problem, let's look at it in isolation. So medicine has, unfortunately, the way things have been compartmentalizing more and more over the last 20, 30 years. It's likely to continue in that manner, although there have been efforts to try to minimize that as much as possible. But for now, we do have good evidence that treating people, for instance, with IBD or with migraines, whichever, whether it's a serious condition or less serious condition, in the context of their general health, will generally lead to better outcomes for the patients, long-term and short-term.
I think it's really interesting, one thing you said there, or just the way you were describing what's happening within the modern medical field. It's almost like two different time frames you're on. You used an expression like we've lost sight of certain things, but also we're beginning to understand. So it's kind of heading in two time directions. I wonder whether you could speak a little bit to that. What would you say we've lost sight of? And would you say that beginning to find out more reflects an evidence base for things that perhaps people knew generations ago?
So medicine has existed in some shape or form for tens, if not hundreds of thousands of years throughout the entirety of human existence. Going back, we think humans probably started 300,000-400,000 years ago, and people have been trying their best to treat their ailments in whatever way they best could. Now, over the last 1,000 years, there's been some attempt to try to bring evidence together, both in sort of what we call the Western world and Eastern world. And the first principle that every healthcare physician of whatever sort always held up was that the patient always comes first. And looking at the patient and trying to do what's best for them was always our first priority. The Hippocratic Oath talks about, doing no harm first, but also trying to help the patient, above and beyond just furthering your own ends. Medicine has become, for the most part, an enterprise. And patients being sick presents to most people an opportunity to make money now. NHS has, in many ways, been probably the last truly socialized healthcare system that's actually doing very well. The basic functionality of NHS, however, is changing. And the way that we are educated now as junior doctors, as medical students, and even more senior doctors, very much will go along the health economic paradigms that are set by people who stand to make money from certain interventions, etc. So the first thing that we do in most specialties, GP, endocrinology, rheumatology, is patient has this condition, what drug can I prescribe them? Now, there are phenomenal drugs. I'm so thankful that paracetamol, antibiotics, general anesthetic exists, and many others. I'm an MS specialist. I see people with very serious neuroinflammation. I am so grateful that we have access to highly effective therapies to help minimize and in some cases completely stop all CNS inflammation in these patients. But the automatic, almost knee-jerk, which medication do I prescribe for whatever symptom, may not always be in the patient's best interest. It would be in the interest of the manufacturers of those drugs, sure. But we need, in the modern world, to think a little bit about patients from a more holistic point of view, because that's really what most patients want. And there's a lot of patients who will want to try non-pharmacological therapies in addition to pharmacological therapy. Some will try the pharmacological therapies on their own. Some will try both, and we give the patients the option. No one's here to say that we're going to replace pharmacological therapy in cases where they're needed. So someone with Parkinson's disease who needs L-DOPA, we're not going to say eat some bananas and maybe try a plant-based diet. That's not going to help you. But knowing in which contexts things are likely to help someone. So someone with IBD, someone with migraines, someone who has a strong family history of Alzheimer's, dementia, especially the typical amnestic version, may benefit from nutritional intervention, possibly some exercise intervention. But the key here is that the physician needs to be aware, or the whoever's giving. It doesn't have to be a doctor necessarily. And the role of the healthcare provider is to be able to identify which patient is likely to do well with which intervention, not just to say, here's my program, pay me £20 a month, and I promise I'll cure your illness. That's not what we're aiming towards. This is high quality, evidence-based medicine. That's what we're going to.
And I think that what you've just said really speaks to, I would say, you're celebrating all the benefits that modern or conventional medicine can bring with the pharmaceutical interventions, the surgical interventions, but you're also coupling that with everything we know about the benefits of holistic and patient-centered approach.
They can go hand in hand. It's not either or. It shouldn't be either.
Okay. Yeah. And do you think that knee-jerk reaction that you were talking about is fresh, is new in certainly Western medicine, or would you say there's always been a desire to have some kind of intervention, something a bit more sexy than?
Everything's an intervention, so a patient taking more care of what they eat and their sleep and a few other things is an intervention. But it's not the patient's fault, it's not the doctor's fault, but we're in an unfortunate situation where the vast majority of people going to see their GP don't have much time with them. They have 7, maybe 10 minutes if they're lucky. The easy thing to do, for instance, someone who is feeling a little bit anhedonic, their mood is a little bit low, would be, here's a prescription medication. It's within the guidelines, you can try it, and it probably will work for 3 to 4 months. But it may not be the right solution. But in the context of a very limited clinic time, you're not given the opportunity to delve into what really the patient needs and what's going on. Everyone's mood fluctuates up and down, but doesn't mean that everyone needs to be on antidepressants. So we have a problem at a structural level, at a process level, when it comes to the organization of healthcare. It's not just in the UK, but with the availability of social media, availability of Nutritank and other organizations trying to increase awareness, hopefully patients, not just the doctors, will start to realize that there are other options out there, and we can present each patient with a multitude of options of how they want to manage their symptoms. At the end of the day, there are some people who will always want pharmacological therapy. But there are many, many others who would prefer to try something else. And they do very well, most of them, if they're identified correctly and the physician or the healthcare provider knows which interventions likely to help.
And would you say, I guess you've kind of said it in some respects there, that one of the key ingredients to that is time. You need time to see what is happening for that patient and to unpick the puzzle, because it's not a 7-minute puzzle.
Yeah. Now, a lot of, ailments that one would go to the GP with would only take a few minutes to assess. I've hurt my ankle. Fine, you need an X-ray and here's some painkillers. But when it comes to much more complicated things such as headaches, people with mood issues which are difficult to manage, you need a lot more time, which is why the specialist, the secondary referral pathway does exist. But most people don't get referred. And vast majority of people are just being managed the best the GPs can. I just want to be very clear here. It's not the GP's fault. They're in a difficult position. They're being forced to manage these patients the best they can. What needs to change is the expectations and the systems that are in place and the processes. And only when you do that will the outcomes change.
Wow. Okay. And I guess I'd love to dig a little bit deeper on when you first began to reflect on these issues, because you speak about everything so succinctly and clearly now. Was it always that way that you kind of understood these changes that needed to happen? Or would you say during your journey to become a clinical neurologist, you began to rub up against certain parts of the medicine you were being taught?
It's a gradual process. When you're in medical school, everything's new, everything's amazing to learn. You're just reveling in the knowledge that you're getting on a day-to-day basis. When you become a junior doctor, you're basically thrown in the deep end. It takes 1 or 2 years, maybe a bit longer, to really get to understand how best to start to treat patients. But with experience, with coming up against various scenarios, which you realize that actually it isn't the patient's fault, it isn't the doctor's fault. There are processes here that need changing. And with experience, you begin to realize that there's a lot more to medicine than just doctor-patient, and there's a lot more going on behind the scenes which needs to be looked at. And there is a process of continued evolution, of rejuvenation, and thinking. But sometimes it's very easy to get stuck and stagnant. And often what happens is when the outcomes are good enough, when money's coming in, people are doing well, people tend not to look and they tend to stagnate. But sometimes what you do need is for there to be difficulty and people thinking, why are people struggling? Why is mental health not being looked at? Why is nutritional health not being looked at? Then you have people who want to make change. They come to the fore, hopefully, and they try to make that change. And change can't just happen with 1 or 2 people. It has to become something that's happening at a more widespread level. Most doctors, most nurses, most healthcare providers being part of that change. And even at a patient level, patients can also have a huge say in what happens in terms of their own care.
And you speak there to the widespread nature of what we need. Would you say when you were having these experiences, having these reflections, did you feel alone, or did you feel like your cohort were having the same reflections?
I think it just depends on the person. I mean, there were people who were so frustrated they decided to leave medicine completely. And certainly from my experience of junior doctors now, a very large proportion, even in medical school, are choosing to leave medicine. So they get the MBBS degree, they maybe do F1, and then they are, the easy thing is to go and join a consulting company or whatever. There are people who choose to stay in medicine, but will go to another country where their prospects are better. Not just their prospects, but also the actual medical system they feel is more conducive to a happier life for them and their patients. And there are some who stick it out, and they choose to make differences. Now, how they choose to make a difference will completely vary from the individual. But I certainly didn't feel alone. The NHS has been under a lot of strain for some time. The last time, and this is before I was a doctor or even a medical student, that the NHS was actually doing very well was probably the late 1990s, early 2000s, after which there's been a very, very significant slide down. It's not fantastic. It's not great for the doctors, but it's especially not good for the patients. But there will always be people who choose to think outside the box, lateral thinking, and think, what can we do which doesn't require a lot of money, doesn't require a lot of investment, doesn't require millions and billions to be spent overhauling systems, but just small interventions that we can make that can make patients' lives better. And that's really, where change comes. Yes, maybe in 20 years' time, we have a radical overhaul of how the NHS functions and how much money it gets, and everyone gets paid fairly. I'm not optimistic, but it may happen. But in the interim, the small things that we do now as individual healthcare providers make a big difference to our patients.
And I mean, just to touch on one thing you said earlier about junior doctors, the kind of emerging workforce, which I know a lot of our audience here at Nutritank are, or emerging healthcare professionals. I think, there's no denying that there are some staggering statistics out there about morale, whether people want to stay in the profession, let alone the country, and practice there. And I think that's quite frightening in some ways, but there are reasons to be optimistic. And I think it's now easier with the internet to find these communities. I know when my mum was training to be a doctor, it wasn't too easy to find necessarily. You could get separated people who did have this preventative mission. So I think in some ways it's a really alarming time, but it's also an easier time to connect with people who have similar values within the health system.
Hey everyone, I hope you're enjoying this episode so far and learning a lot. For those of you who are new listeners, welcome. If you're finding this information valuable, I would love for you to consider joining our regular listener family. Just hit that follow button wherever you're listening and you'll never miss a new episode. By the way, one of our main goals is to educate as many healthcare professionals as possible about the power of nutrition and lifestyle medicine. So if you know someone who might benefit from this information, whether it's a colleague, friend, or family member working in the field, please consider sharing this episode with them. Now let's get back to the show and dive deeper.
Sure, I agree. Internet is a tool. You can use it for good, you can use it for not so good, I guess. But it has allowed people to have increased awareness that they're not alone and they're not the only ones that are thinking this way. And you can find communities of people very similar to yourself, sure.
And now, as well as being a clinical neurologist at a large NHS practice and an educator, you also call yourself a preventative physician. What does it mean to be a preventative physician?
I mean, it's not a term that I would use. I believe that I am a metabolic health specialist. Now, the problem with metabolic health is you can interpret that in a multitude of ways. As neurologists, there are very clear types of metabolic health practitioners who see patients who have usually inborn errors of metabolism. So there's some genetic defect, which means that you can't utilize fat, or you can't utilize glycogen, or something like that, or amino acids can't be manufactured. These are incredibly rare, but they specialize in that. And in the same way that a neurologist may specialize in movement disorders or stroke or inflammatory disease. That's not what I'm talking about. Every single cell in your body, of which we have trillions, requires energy. And in order to produce energy from the food we eat, you need to have a intact and efficient metabolic apparatus. Now, the metabolic apparatus is vast. It's not just, a furnace and we just put food in and it burns the food and we create energy. It doesn't work like that. It's very complex, very interconnected. And what I have come to find over the last 10 years or so of doing this kind of work is that if you understand the junctions at which the various different components of the metabolic apparatus can start to dysfunction, then you are very well placed to think about preventing health from degenerating in the first place. So modern medicine will see patients once they get ill. I've had a stroke, I need to see a doctor. I've had a heart attack, I need to see a doctor. Or an impending heart attack, I need to see a doctor. And, we've made some attempt at trying to prevent things happening. So we have surrogate markers of ischemic heart disease. So, your cholesterol goes up, which is a very poor predictor. But again, it's one of the ones that are used. Your, blood pressure is high, which is a good predictor. You have They're of a certain age, certain sex, certain family history, and we can try and calculate risk scores, which are very poor, but again, there's some attempt to try to prevent ischemic heart disease or cerebrovascular disease, for instance. And then you can prescribe medication and interventions to try to reduce that. But number one, a lot of these predictive markers are very poorly predictive, and they're based on evidence which is, I don't want to say non-existent, but it's poor. And we have much higher quality data that we've been accumulating almost on the sideline. People have ignored them for some time because they didn't fit into the standard narrative. Thomas Kuhn was a philosopher in the mid 20th century, I think in the 1960s, who talked about knowledge revolutions. The idea that we have a standard way of doing things, and evidence that accumulates that doesn't conform to the standard narrative is kind of, just ignored. But there does come a point where the alternative evidence reaches a critical mass, and people have to essentially go through a revolution in what they believe to be correct knowledge. And we've gone through that a few times in medicine. And obviously, anytime something becomes standard practice, there are always people who will gain from it, and it is in their interest to keep that practice going. But we've had multiple knowledge revolutions when it comes to nutritional health, to brain health, to cardiac health, to metabolic health in general. But actually, more recently, there's been big changes in psychiatric health and how we might manage that going forward. And hopefully, we're in a position now to start making those changes more well-known and more widespread. But as usual, the problem that we have with guidelines, by the time they're out, they're already 5-10 years behind the evidence base. So there's a way of balancing what is current standard practice and trying to help patients to advance their health without necessarily being too avant-garde and saying, here, do this and we'll cure your HIV. It doesn't work like that. We need to know what's going to work, what's likely to work in which patient. And that's what I say this quite often. The role of the healthcare provider who's in this space is to understand what's likely to work. It's very easy to become dogmatic and just have one intervention that you give to everybody. It doesn't matter. They come with arthritis, they come with headaches, they come with Alzheimer's. You give them that one plan that you give to everybody else. That's easy. That's not what we're advocating. We're advocating for a different type of way of thinking about medicine at a cellular level, which, again, probably will prevent 300-400 chronic diseases if used properly. So yes, preventive healthcare, physician is a label one might use if they don't know what they're talking about, or integrative healthcare physician or functional medicine, whatever. These are all very similar terms. I believe that my knowledge base in metabolic health would make me someone who is a specialist in metabolic.
Okay, yeah, and that metabolic apparatus, as you said, within the medical model has been treated like a furnace. If it was treated like a furnace, how should we treat it now?
A very simple, maybe simplistic model would be thinking of it a bit more like the engine of a V12 engine car, where lots of different things have to work in unison for you to be able to utilize the energy created by the petroleum in order to make the various pistons and whatever the different parts that move in the engine, I don't know all the names, work to drive the car forward efficiently. But unlike the furnace, if you were to mistreat the engine or the metabolic apparatus, the metabolic apparatus starts to degrade. And food isn't inert. The food exerts an effect, either positive or negative, on the metabolic system. And what you'll often find is, most of your listeners are probably in their late teens, early 20s. They can probably eat whatever they like. There'll be a proportion of people growing every generation, actually, that won't be able to, because they've already started off from a very early age with poor metabolic health. But you can eat whatever you like. You can sleep as little as you like. You can drink as much alcohol, smoke as much cannabis, take whatever drugs, LSD, whatever. I don't know if LSD is popular, but whatever people take. And their body will recover. But there will come a time where repeat abuse will mean that your metabolic apparatus isn't functioning as well as it used to. And Usually it's in the late 30s, early 40s. The same interventions of running, going to the gym, eating a bit less, doesn't work anymore. Because what's actually happened is that metabolic system has started to fail. Now, unless it's on its last legs, the good news is you can actually heal it. But knowing how to heal is the key. And there isn't one intervention, there's multiple interventions. And some of them are the opposite of what you might suggest to someone else. Dogmatism is not the key here. You can't be like, well, everything's plant-based, everything's carnivore. It's not, it doesn't work like that. Knowing every one of those interventions, we have 8 or 9 interventions you can use metabolically, which may help someone. Each one can help the right person at the right time, but could do damage to the wrong person at the wrong time.
And I remember you discussing that dogmatism with a diagram or a kind of cartoon that's often I've seen a few times at these integrative conferences, which is an elephant surrounded by doctors. Would you like to explain that?
Yeah, I mean, it's a common paradigm. Or an allegory, perhaps, of the blind men, I guess blind people now, and the elephant, where each one is holding on to a different part of the elephant. And because they have no awareness of the other parts, so one will be holding on to the trunk, one will be holding on to the tail, one will hold on to the legs, one will hold on to the tusks. Each one believes the part of the elephant they're holding on to is a whole. So an elephant is tusks, elephant is a tail, elephant is that. But the reality is most of these scientists that may seem diametrically opposed to each other, so the plant-based scientists versus the carnivore scientists versus the low-calorie scientists versus the low-carb scientists versus the low-fat scientists, and a few others, they're all holding a part of the puzzle. They're looking at the same problem through a slightly different lens. And for many, many reasons, they have some incentive to promote that idea. And we see that quite often. There are plenty of professors of nutritional science with 700, 800 publications who will not consider an alternative view. And it's a shame, but I guess what I often remind myself is that the people who've already set up their stalls and they've already chosen the hill they're going to die on, as it were, they're not the people we're trying to convince. We're trying to educate and bring awareness to the masses, the 99% who don't know, who are agnostic, who don't really care. They just want to make their own health better. We just ignore the ones who are just, they will not change, and just move on and try to help those who want to be helped.
And like you've said, there's many components, and each person who's set up their store, who's said this part of this whole thing is the tusks, this whole thing is the tail, this whole thing is the legs, holds a part of the puzzle. Would you say they combine to form anything meaningful in the context of metabolic dysfunction? Could you distill it into one part of the elephant, perhaps?
It's impossible. I guess the I forget what it's called now, the Pareto principle, where for most people, 20% of what you do will give you 80% of the results. I think that probably applies, and especially if you're already in some good health. So if you look after your nutrition to a certain extent, if you look after your physical health through some form of exercise, make sure that you're not chronically stressed, make sure that you're sleeping well, and you're not unnecessarily taking harmful exogenous chemicals like smoking, excess alcohol, things like that, you'll probably do very well. You could still get hit by a car the next day. You could still, have been born with a genetic problem that you didn't know about. And, there could be an outbreak of some highly infectious virus or bacteria that could happen. And you might die in your 20s or 30s. But for the most part, doing the simple things will prevent most disease. But there are people who, through their own, through not their own fault, have been born in metabolic ill health. There is very much a concept of metabolic privilege, where some people are just born in the same way some people are born into rich families and they have the genetics for good height and good bones. Some people, unfortunately, are born with poor metabolic health because of the context that they were placed in. And these people have changes that one might see in people in their 20s and 30s who have poor ill health, but they start off at a much worse position much earlier on. And you may feed them the same food, but they'll gain weight. They'll gain weight quicker. You may give them the same amount of food, but they won't feel satiated the same way that someone without those metabolic changes do. So there is inequity there, but identifying who is likely to benefit from metabolic intervention, which is above and beyond the simple dogma that we have, exercise a bit more, eat a bit less, that will work for some people. But every generation that passes in our current nutritional paradigm, that will work for less and less people. And then identifying how to fix that metabolic dysfunction becomes key. And if it's the tusks, it's usually never just one thing. You need to treat the tusks. If it's the tail, you need to fix the tail. If it's, the trunk, you need to fix the trunk. But being able to identify what the problem is really important.
Yeah. And would you say if it is the tusks, that's a proximate problem, that's a proximate cause, and you describe the root cause approach to medicine, and I guess where do you start with that root cause approach?
Not everything will have the same root cause. So if you happen to be someone who has a genetic malformation, at present there's little we can do. Now, it's possible that in the future we may be able to use techniques like CRISPR to be able to change people's genetic code. Now, we can technically do that at a single cell level. I'm not a geneticist, but certainly my reading is that we can do that at a single cell level. We have, I think, something like 10 trillion cells in our body. How can you replicate that? Because every cell has the same genetic code. Even a liver cell and your retinal cell will have the same genetic code. How do you change that? I don't know the answer to that, but we have no interventions for someone. If you're destined to have the very rare form of Alzheimer's, which is autosomal dominant, then you're going to get it. There's very little that we can do. But for probably 300 of the most common metabolic conditions, diabetes, obesity, hypertension, lipid disorder, I don't want to say hypercholesterolemia, but dyslipidemia, migraines, polycystic ovarian syndrome, loads of others that not even come to mind, there probably is an underlying metabolic dysfunction, which probably is a combination of your environment, the food you eat, the amount of sleep you get, and the amount of exercise you do or you don't do. Probably, but of which food will probably take up 80% of the root cause.
And so I guess we've talked about these conditions like this rare form of Alzheimer's, which you're destined to get.
A lot of people talk about dementia and Alzheimer's like they're the same thing. They're not. Not all dementia is Alzheimer's. Alzheimer's would make up probably just under 2/3 of all dementia. But Alzheimer's isn't one condition. And you have the typical amnestic variation, you have behavioral variance, you have language variance, you have a very unusual one called posterior cortical atrophy, where people have visual processing issues. And there's lots of people who actually have the pathological hallmarks of Alzheimer's but never have any symptoms. But very, very rarely, probably less than 1% of the time, it's genetic. And, there are clear three, as far as I know now, 3 genes, there may have been a fourth that we found, 3 genes which lead to autosomal dominant variants in your genetics, and you're going to get it. But less than 1%, probably 0.5% of all Alzheimer's is caused by that. So 99% plus is not due to that. And even if you have other genetic malformations, so you have a genotype which is ApoE epsilon 4, and you're homozygous for that, your lifetime risk of developing Alzheimer's is something like 70 to 90%, but potentially still fully preventable. So, it's very nuanced. Being able to understand what someone has, number one, what's the genetics, if they're worried about Alzheimer's. We're using Alzheimer's example, an extreme example, to be fair. But still, for the vast majority of people, if there is a very strong family history, even if they have early symptoms, we believe now we're in a position to help them. It's not standard care, and it's certainly not just dishing out drugs. And, you may, I don't know how much you're in sort of aware of what's going on in the world of Alzheimer's, but A couple of drugs had been approved by the FDA, aducanumab and lecanemab. Aducanumab caused quite a bit of consternation amongst lots of people, and lots of people resigned from the FDA, but lecanemab was more celebrated. But they very likely do very little in terms of real world. But it's the first thing that we have that may make a difference. Now, I'm not saying that no one should use it. There are potentially very serious side effects, such as brain swelling and brain hemorrhages, which is not insignificant and affecting a significant amount of people. But it can potentially still be used in the right people. But there probably are much simpler things that one can do to try to reduce the risk of at least typical amnestic Alzheimer's or other forms of dementia, maybe. Parkinson's, we don't have good data on. Vascular dementia and typical amnestic Alzheimer's actually have quite similar risk factors outside of the genetics. So we probably can help. But things like genetic frontotemporal dementia or even sporadic frontotemporal dementia of its various types, we probably don't have enough data on to be able to definitively say we can help.
I mean, and it's really interesting you talking about this, the nuance, like you said, behind what we might have thought generations before as inherited or as genetic risk factors for certain conditions. And I think certainly with a large part of the patient base and population, they can see what happened to their parents or their grandparents, whether it's heart disease, strokes, and they almost see it as an impending situation, which is coming to them down the line. And I guess if we appreciate that so much of the metabolic dysfunction is not this kind of destiny, someone's written it down and it's awaiting you, but actually a lot of it can be acquired or influenced by our lifestyles. Yeah, where does that acquired metabolic dysfunction come from? Would you be able to speak a bit to that?
It's mainly food. It is mainly food, and the nutritional landscape has changed massively over the last 100 years. How often we eat, what we eat, who makes the food, that's all changed, and that's probably the biggest contributor. I don't know how much detail you want me to go into, but it's not the only thing. But if someone wanted to do something to really, really change, potentially change their future health, is really try your best to avoid processed food. Now, ultra processed food is a specific term. Highly processed food is a different term. Processed food is a different term. Olive oil is processed food, but olive oil wouldn't have the same negative impact that a box of Cheerios would, or your Wotsits that you eat sometimes would. But they're still technically processed food. When you chew food, you're processing. We're not talking about that kind of minimal processing. We're talking about factory-made, designed by people to try and make food as tasty as possible. And the processing itself, often the things which are being processed are very refined carbohydrates to begin with, which are too easily absorbed. The carbohydrates themselves aren't a problem. I think a lot of people get very fixated on sort of carbs and fats and proteins and macros. But if you highly process carb, they become very readily converted to glucose very high up, so proximally in the GI tract, which causes a very non-physiological stimulation of the incretin system. And then you get a non-physiological effect of the various incretins. We know of 2 incretins at present, GIP or GLP-1. There's probably others we don't know about yet. But that has widespread effects, including at your hypothalamic level, at your pancreatic level, in addition to reduce insulin. But a more physiological way of eating would be, if you're going to eat a carb, make sure that it's something that's very slow to digest, because the further down your GI tract that carb is fully converted to glucose, the less likely you are to have an abnormal physiological response to it, and much more likely you are to have a good functioning metabolic system. Again, very complicated, and I wish we had 10 hours to go through all this today. I mean, I could talk about this for days and days at a time, but the simple thing is, it's not necessarily the carb, it's how much has been processed. And then we also know that the mixing of carb and fat is very, very, very unphysiological, because you don't really get that in nature. And that's something that our human systems are designed or evolved, however you want to look at it, to eat. So if you really want to eat rice, have the rice on its own, but don't have it with butter. And don't mix it with oil, and just have it on its own. In fact, someone with diabetes, we have studies that have been done on it. You could probably reverse it just by eating rice. The Chinese paddy farmers, 100 years ago plus, would subsist on a diet of rice, and they never got diabetes, despite rice being very high GI index. But if you didn't, process it, and you didn't eat it with fat, you'd do pretty well. I'm not suggesting people do that. They'd be pretty nutrient deficient, micronutrient deficient. But, same thing, if you chose to just eat meat for some time, for a short time, you could probably get rid of diabetes. But it wouldn't be something you'd want to do long term.
Are you a healthcare professional looking to elevate your knowledge of nutrition and lifestyle medicine? Nutritank CIC wants to empower you to have the communication skills and knowledge of lifestyle medicine to improve your patient's health through free CME accredited webinars hosted every Monday evening. Learn from leading experts in the field and gain access to cutting-edge research and best practice. Here's what you gain through our webinars. Enhanced knowledge of nutrition and lifestyle medicine and applying it in clinical practice. Continued medical education credits to maintain your license. And free access to a library of previously recorded high-quality educational webinars. Take action now. Register for upcoming webinars or become a member at nutritank.com. The links will be provided in the show notes. Invest in your clinical practice and patients' well-being and fuel their health with Nutritank CIC.
And I mean, so we're just really emphasizing the importance and the prominence of diet within this whole space. I think sometimes it's easy to think about lifestyle medicine as this thing that's split evenly. Would you say diet is the main player within metabolic function distinctly, or across the whole scope of chronic diseases that we see within our health system? Do you think that that pie chart of lifestyle medicine, which might be split into 6 or 7 or 8, no matter how you define it, do you think the biggest part of that should be food?
It won't always be in different societies, different environments. For instance, if you were in a society where actually food is pretty good, but no one ever did any exercise, then the rate limiting step would not be the food. It would be a lack of exercise. But for now, in our current nutritional landscape, it's 80% plus food.
Okay. And I think that's the key thing. As you mentioned earlier, the changes we've seen, and you could just watch the Chris Van Tulleken, What Are We Feeding Our Kids, to see a big, a really key picture where he demonstrates kind of bird's eye view with how much of our household spend on food was dedicated to whole foods versus ultra processed foods in the 80s, and compares that. There's been such a radical shift in how we're eating now versus 50 years ago alone, that you're right. I guess it's not necessarily this level playing field where we can look at all aspects of lifestyle medicine and say they're all an even influence.
Yeah, and I'm glad Chris and his brother Xander are doing work to try and increase people's awareness. I think Chris had a book came out relatively recently, Ultra Processed People, which has been in the media quite a bit. So we need awareness of that. I just want to be clear, it's not the only thing. The processing of food isn't the only thing, but for most people, most of the time, that sort of Pareto principle, if you just did that, especially as a child and in your teens and 20s, you've probably gone some way to minimizing damage, damaging the metabolic system in many ways. It's not the only thing, but it's a big thing. If you have to do one thing, that's that one thing that's a bad idea to do.
Yeah, I think you're very good at demonstrating the nuance and the multifaceted nature of this. I think when you listen to kind of maybe pop science on health podcasts, it's tempting, like you say, when people have set up their stool to just hide behind, there's other stuff which is important, but this is the main thing. And I think it's really refreshing to have that. And one aspect you touched on of ultra processed food in your presentation at IPM was this interplay with dopamine or dopaminergic reward networks. Would you be able to speak to that?
So dopamine has been in the public conscience for some time, but people misunderstand it. It's a neurotransmitter which has effects at a central nervous system, but also at a systemic level. But we're really interested in its central nervous system effects. People will probably be aware of Andrew Huberman and a few other people who've become very prominent over the last few years talking about, dopamine and a few other neurotransmitters, but mainly dopamine. I think the thing which made Andrew Huberman particularly famous was the dopamine sort of podcast that he did. I think at one point he was one of the top 10 podcasts in the world because of that, the deep dives he'd go into. But still, people don't understand it fully, and this is both at the public level, but also even at a sort of neuroscientist, basic science, but also the sort of translational bedside and basic research scientist. But what we understand is that dopamine has a number of different roles, including in coordinating appropriate movement, which one would see that if you had, for instance, lack of dopamine in those pathways, I won't go through all the different technical names, but you may get a condition like Parkinson's, where you have lack of movement and people become very slow and rigid, and in many cases get a tremor. That's one simple way of looking at it. But the other thing is reward networks, and it isn't that you do something and you get a dopamine hit as a reward, because that's how people think of it. But what actually happens is the anticipation that I'm doing something and at some point I'm going to get hit by something I like is where you get your dopamine from. And it's a subtle difference, but it's a big enough difference that it should change how we think a little bit about something. So if you're scrolling on your Instagram or TikTok feed going downwards, when you're going down looking for something to watch, that's when the dopamine's building and rising and rising and rising. And then when you get it, it kind of then plateaus at that level. So that dopamine rise, that dopamine hit, that sort of reward network is very much in anticipation of getting something that you want. It could be food, it could be sex, it could be whatever. But it's not necessarily because of that, of the actual activity itself. Often the chase is greater than the actual, whatever the outcome, the end result is that you want. But what we find is in patients who have abnormal eating habits, if you were to do functional MRI imaging, often there are abnormal signaling in the dopaminergic networks in the brain that relates to reward, risk, reward, motivation, these kind of things. And it's not dissimilar to seeing the brains of people who are cocaine addicts, for instance. So, a relatively well-known study from about 10, 15 years ago looked at the brains of people who are addicted to high sugar foods. And in fact, what was surprising to the people doing the fMRI at the time was that the radiological changes were much greater in the patients with sugar addiction than cocaine addiction. And common, I think one of the things that paper became quite famous was people then started to say that sugar is more addictive than cocaine, which I'm not sure it is, but at least at a brain level, it looks like it probably is more addictive, on an fMRI. Yeah, sure. But it's not just food. It's not just food, right? Because I mentioned social media. And, if you start to overstimulate that sort of motivation, risk, reward pathway, you can start getting aberrant effects. And what we're finding is because of especially TikTok, but Instagram, Facebook, YouTube, Shorts, but even the longer form videos, people are so used to scrolling on their phones that when they're without it, people often find, especially if they're without it for some time, they find the mood's better. There is a real negative impact of social media usage, especially TikTok. Again, I don't know if it's necessarily just TikTok, but especially TikTok, because a lot of the work's been done on it recently, on causing unexplained anxiety, depression. And the more time you spend away from it, not using it, the better your anxiety and depression scores, especially in teenagers and young adults.
And it's really interesting exploring that scrolling aspect of it. I think you painted it really well in that with social media, where you're not eating something which we would consider harmful, but the main activity is this kind of searching, this anticipatory thing, this never ending. And so that's what we could almost see that as a bolt-on to the negatives we already understand within the evidence base of ultra-processed food. If we've got this anticipation, which is perhaps interfering with our neurological systems, but B, all of these, interactions between highly processed carbs and fats that you've said, and all of the other things that come from ultra-processed food.
The thing with ultra-processed food is these didn't come into being by accident. These are designed. Focus groups, testing, is this 10% tastier than the other product that we have? How much sugar do we need to add? How much salt do we need to add to make it tastier, essentially? I think the term that had been used in the industry was bliss point at some point. I think that's what they used to use. I don't know if they still use it, but this is the scientific method used to create addictive food, because it's in the interests of, whichever food manufacturer you choose. I won't name any, but to make food that people want to buy. And if you make it addictive, even though it's not addictive in the same way that, drugs of abuse can be, but they behave in a very similar way. When you eat food which is not processed, satiety is typical. When you eat ultra-processed food, it's designed to make you want to just keep eating. You just have that urge to keep eating. I think that if you look at adverts, they say it's very Moorish. It's designed that way. It's like you eat it and like, actually, I don't know why I've eaten 6,000 calories worth already, but I want to have a bit more. And it's very easy to do, especially if you're not concentrating, if you're not cognizant and aware while you're eating. It'd be very easy to overconsume very quickly. Which I think we've struck at the heart of why a lot of things start to go wrong metabolically with ultra-processed food. The ultra-processed food itself is unphysiological, but it's also designed for you to eat a hell of a lot of it.
Yeah. It's not necessarily an even playing field when you go to pick up a piece of ultra-processed food. One of the biggest things which you've spoken to just there, which can be quite a revelation to some people, is this idea that is satiety levels. And I think Chris Van Tulleken speaks to these increases and decreases of hormone levels for the satiety and the hunger.
Yeah, so that basically is control of the hypothalamic level. So within deep in the brain, you have pathways for, they're called orexigenic and anorexigenic, but which means pathways to help you lose weight or to gain weight, essentially. It's called the leptin melanocortin signaling system. It's not just leptin which acts on it. Insulin, GLP-1, GIP, ghrelin, they can all act on it. But yes, you get complete overstimulation of those, and they become quite resistant. The receptors in the hypothalamic, I'm pretty sure it's the arcuate nucleus, although don't quote me on that. They become completely resistant to that stimuli, so you lose that resistance. And I mentioned maybe a short while ago about children being born in that position. You can get into a state of what's called metabolic imprinting, where mothers who are either overweight, actually interestingly, or also very underweight, we can see them both. Children are born with elements of insulin resistance, but also leptin resistance, where they're just not satiated from day one, and they have to eat more to get that same level of satiety. So they start off in a very metabolically unprivileged state, unfortunately. And what we see now is these are the people who really, really struggle to lose weight. The weight itself isn't an issue. It will become an issue after a while, because your knees and your hips and your spine, will start to really, really struggle with your ankles as well, potentially. But in and of itself, subcutaneous fat's not a big problem. Once you cross a certain threshold, it starts to become metabolically dangerous. But there are plenty of people walking around with a lot of fat around their buttocks and thighs, which actually isn't dangerous metabolically. But visceral and ectopic fat, which is around the organs inside, deep inside your abdomen, is metabolically very dangerous because of the what's called the stromal vascular fraction being quite large and metabolically active. But these poor people who can't lose weight, eventually you then have this acceptance that I'll never lose weight. And then what we've seen more recently, again, this is one of the sort of downsides of social media, is people like this often start talking to each other, and then they create these fat acceptance movements. And then essentially you have this idea that being fat is normal, being fat is good, and there's nothing wrong with it. And actually, it's a choice. But the reality is, had there been a little bit more nuance in helping these people at a younger age, and not just saying exercise a bit more, eat a bit less, because their metabolic systems are damaged, they wouldn't have ended up in this position. Now, we didn't have the knowledge of this that far back, but we now have that knowledge. And there's some data actually that giving leptin to young children, young babies, can help satiate them and stop them getting into that very deleterious sort of cycle. Now, I'm not suggesting we start going around giving leptin to every child to stop them getting fat, because that's not what we're in any way suggesting. But these are just preliminary proof of concept works that we need to think more about, and leveling the playing field from a young age so that everyone can enjoy good health. Not, again, we're not demonizing people who are a bit bigger or people who are a bit smaller, whatever. Body positivity is, or at least should be, the understanding that not everyone's going to be 6'4" and ripped with muscles, or not everyone's going to be skinny, whatever size models are. But you can be, someone will have slightly bigger waist, someone will have slightly bigger hips, someone will have slightly smaller boobs, whatever it is. As long as you're healthy, that's fine, rather than just promoting a single look for a man or a single look for a woman. But unfortunately, the body positivity movement has become quite I don't know what the best word is. Toxic is an overused term, but I think toxic is that term. And these are very angry people who have tried everything and they're just giving up, and they think the world should just, accept them. But what's going to happen, actually, unfortunately, we don't stem the tide, is that 70 to 80% of people will be fat. So without realizing it, we'll all be, body positive. Again, being fat in and of itself isn't the issue, but we'll be unhealthy, and it's not good. There are countries already, like in the some of the Pacific Ocean islands, where 80% of people are diabetic. That's not good. That's not good. There's no need to be body positive there. I mean, it's not about the fat; it's about the metabolic health. That's what we need to try to correct, and we should make it easy. Anybody, if they chose to run a marathon 2 times a week, would lose a lot of weight, but that's not what's needed. If you watch these programs where they take people who weigh 300 kilograms plus, they push them to such an extent that they're vomiting, that they're hating their life. But what happens is, when you watch that, you start to think, God, if that's what's required for me to lose weight, I don't want to do it. We need to make it easy. Make weight loss, it's not the weight, make health easy, make ill health difficult. That's how we should be thinking. But unfortunately, the chips are stacked in the opposite direction at present.
Yeah. And I mean, we're coming to the end of almost an hour now, and I'm aware that we've almost just scratched the surface of so many things that I would like to talk to you about. But one thing I really would like to touch on before we get to our closing questions is the fact that you may have been one of the only speakers at IPMC who didn't have any significant online presence, I would call it. No account for LinkedIn, no account for Facebook, Instagram, YouTube, and definitely no TikTok, as we've said. How hard would you say it is to spread your message without all of these mediums?
I think I touched on this before. Change isn't going to come from one person. Sometimes it does happen that there is someone that's so eloquent and so well spoken, or they have such reach that they say one thing and it changes people. That's very rare, very rare. Change has to happen at a societal and institutional level. My role isn't to go on social media and do a few dances and try and tell people to eat a different way. It probably might get some views, you never know, but that's not the intention, right? I have a job that I enjoy as a doctor. I love seeing my patients. I really enjoy my work. I'm very lucky to do what I do. I'm happy to do that. But I educate everyone that comes through my clinic. I have lots of medical students, I have lots of junior doctors, and I have lots of patients. And when you start to educate people, and again, you don't do it in a way which is preaching. Say, think about this. Here you go, and give them some information they haven't heard before. You can whet their appetite for learning, because most people have the capacity to learn. And if you make science interesting, if you make nutrition fun, and rather than, I remember sitting in lectures in my first couple of years of medical school, just literally thinking, what on earth am I doing here? It made no sense. But the same lectures now, they are absolutely fascinating. Understanding the Krebs cycle, which was just like the worst thing in the world. And I just didn't understand why I was doing it. Like, I just want to go and treat patients. But actually now it makes so much sense. So implanting a seed of fascination, of like, this is fantastic, and making science and nutrition, and not just nutrition, but all aspects of science and medicine, just something that should fascinate you, something that should just enthrall you. That nothing can do that. But once you've implanted that seed, people will go and learn from themselves. And obviously you point them in the right direction, because you don't just spin them around in circles and say, go on your way, whichever direction you choose will be right. It doesn't work. And you kind of give them, a few tidbits of information of where they want to start looking, and what they need to learn first. But then they do it themselves. It doesn't require me to hold their hand for very long. Obviously, if there's patients who are very ill, who need specific metabolic guidance, fine, I'm there for them. But I deliberately choose not to have social media, just because as I say, the weight of evidence is very clear. YouTube is fantastic. TikTok has maybe some use, I don't know, but possibly. But me being on there with the intention that I'd like to spread a message is like giving someone lots of poison and then just putting a tiny bit of the medicine in there, saying, here you go. It's not a good justification. So I'd rather just not. I'd rather stick to my guns and say, what, I feel so strongly about it that I'm not interested.
I think that's amazing, and I think, if more people could follow that principled approach, then perhaps it wouldn't be feeding. We could call it the furnace of social media.
We've let Pandora out of the box, or it's not Pandora out of the box. It's Pandora's box. We opened Pandora's box. It wasn't Pandora that was inside, was it? But and even if we got rid of TikTok, people have seen how popular it is, how much money potentially. It doesn't generate much money at present, I don't think. I think it probably could do. I think people will still do it. And, everyone now has something very similar. Instagram is something similar. YouTube is something very similar. And it'll just be a matter of time. But at an individual level, if you can limit it, I'm not saying don't use it at all. I'm not saying it doesn't have its uses. I don't think it does, but it's possible there may be something useful on it. But limit it as much as possible. The evidence is clear. And especially if if your brain is still developing, most people's brains develop fully at the age of 25, 26. So a developing brain is particularly prone to the effects of something like this. So you see lots of children watching it, lots of teenagers watching it, and even people in their late teens, early 20s. That's not a good age to do it. I'm not suggesting when you're 50 you should watch it and it's better, it's fine. It isn't. But the risks are particularly high with the developing brain. And that's why we see the biggest ill healths in that demographic.
And that this potentially could be your answer to the next question. I was a bit apprehensive coming up to it, because I was aware that you probably were never going to give one answer to a self-care tip. But do you think, for our audience, young professionals or young students who are trying to make a healthier country, a healthier planet, do you think that could be a really important self-care tip to give?
It would be that, or the processed food. I think I mentioned the processed food, that if you had to do one thing with your nutrition, and I think this was a talk about nutrition, so let's keep it to nutrition. Just try your best to 90% of the time not have ultra-processed food. Now, everyone likes a pizza once in a while. Everyone likes to eat McDonald's burgers once in a while. But this is all ultra-processed food. The bread's ultra-processed. The meat's ultra-processed. If they could find a way to ultra-process the tomatoes and the lettuce, they'd do it. But that probably isn't the concern. But if you can, say 13 days out of 14, not have it as part of breakfast or lunch or dinner, and still eat very tasty food, you'll see big changes, and your palate starts to change within days. Food that you found delicious, when you next have it, tastes too sweet, too salty, too unpalatable, and you kind of end up getting a reversion for it. So in terms of food, I think just doing the best you can to get rid of the ultra-processed type of food from your diet would be the biggest tip. It's not the only thing, but it would be the biggest tip for most people.
Brilliant. And if we can think about the community as a whole and the kind of the future we're entering into, what would you say is one strength we need to cultivate in order to maximize our chances of creating a healthier future?
So the answer would be a little bit different, I suspect, to what most people give you. And I think it's humility, because we've recognized, going back thousands of years, that the first stage of knowledge acquisition is always arrogance. Now we've kind of codified it into, we call it the Dunning-Kruger effect, I think, because social media has now popularized that study. But we've known about it for some time, that when you are at the first stages of knowledge and you know what probably 90% of people don't know. So if you read one book, you know more than 90% of people. It's very easy to think you know everything. But you need to push through that and just keep learning. Be humble and say, what, I've learned something, but let me learn more. And don't ever stop learning, because the arrogance that something that others don't know can stop you from truly developing yourself and helping others. So remain humble in your studies. It takes a long, long time to truly acquire knowledge. And really only when you start to feel humbled by the amount of knowledge you've learned should you start to teach. That's what I say to people. Don't, in medicine, we have this general rule of thumb: see one, do one, teach one. You see a chest drain insertion, you do a chest drain insertion, you teach it. That might work, maybe for taking blood or for cannulas or for simple procedures, but for something as complicated as your health, something as complicated as the metabolic apparatus that we all have, and how they can go wrong, it takes years and years of learning. And there are plenty of opportunists out there who see this as a way to make a bit of money. A lot of people now, because of various social media influencers or whatever, realize that the next stage of medicine probably is preventive healthcare. And people that I know who have no real interest in it think that may not be a bad bet to have a small preventive healthcare clinic. But I mean, preventive healthcare, longevity, metabolic health, however you want to call it, clinics like that have existed and will exist. But the ones that truly practice excellence, and people who are truly practicing excellence, are very rare. And try to remain humble, never stop learning, and try to be those that practice excellence rather than just try to go for a cash grab, because that's not going to change anything.
Yeah, and it's clear there's so much depth to this. Maybe we could have just asked these questions at the start and had a whole podcast about it. But if I can bring it on to the final one, what resource would you say would be a good one for our audience to go and look at?
That's a difficult one, because I can't recommend one book or one person, because the thing is, each one of the big influencers will have their own various vested interests in something. I don't have any vested interests, so I just try to be as agnostic as possible. I will be a little bit tangential and say that one of the biggest shortcomings that I see, and I'm assuming that people will go on to be scientists and doctors. Not everyone will be, but I guess most of your demographic probably at some point will become a scientist or a doctor, is spend a little bit of time really trying to understand the philosophy of science. Because science has its own philosophical assumptions. And if you understand it, and you understand how it's different to the philosophies of mathematics, for instance, and actually the philosophy of medicine, which is not the same as science, you're in a much better position to build on that foundational framework your further knowledge. So just going off and learning a little bit about the Krebs cycle and, what happens to your pancreas when you eat and all this kind of stuff will be helpful. But in order to process that and know what to do with that information, if you understand, for instance, how deduction is different to induction, which is different to abduction, which are all three different things. We may use them similarly in common, in common language, in common conversations, but they're very different when they apply to mathematics, science, and medicine. And what the foundational principles of science and medicine are, you're in a much better position to really do something with it.
Wow. I think that's a really good, encouraging resource or avenue to recommend people to go down. And it's not one that necessarily people would think of first. And usually at the end of our podcast, we ask, where can our audience find you? But I'm sure they might understand now why that might be a bit difficult. But I guess, we could say, where could they find your message? Where could they find you in a metaphorical sense? Maybe?
Well, I have a website, which is the website of my clinic. It's a very small clinic. We only see 1 out of every 100 clients that sort of want to work with us, because I don't think I can help everybody. And also, I have a very busy NHS practice, so the clinic is still very small. But if you went to the website, so it's the London Centre for Longevity and Metabolic Health, lclmh.com. You can get in touch with me that way if you wish. But you're not going to see any videos of me or any of me on TikTok on there. That's what you mean. It's not going to.
Okay, so they can't find that anywhere.
Well, I mean, I have an OnlyFans, but that's something different.
Okay, well, I think that's a perfect way to end the podcast. And I'm going to wrap it up now. But it's been a pleasure having you on the podcast. Thank you so much, Shahrukh. I feel like we could have had 10 more episodes. Thank you for your time.
Thank you for your time. My pleasure.
We hope you enjoyed this episode. If you did, share it with your friends and family and drop us a review on your preferred podcast platform. Don't forget to follow the show on your favorite streaming platform and connect with us online to stay up to date with all the latest news and episodes. If you feel engaged with a particular aspect of today's show, then please comment on our social media posts for this episode. They'll be linked in the show notes. See you in the next episode.